Why don't we start with you telling us a little bit about Included Health? I think you have a few slides as well.
I'm the Chief Health Officer at a company called Included Health. And our mission is to raise the standard of healthcare for everyone. And we do that by providing all-in-one personalized healthcare. So I'm going to ask you all to take off your clinician hats or health systems hats when I talk, and just think about yourself or your family members as people who are experiencing the healthcare system. Maybe you have some of your family and friends that are experiencing the healthcare system right now. And that is the center of everything we do. We center ourselves around the person. So what was Grand Rounds? That's the company I joined. Our initial mission was to democratize access to expertise. We did that by providing expert medical opinions for people who lived anywhere in this country. So if you live in a rural part of this country, you deserve to get the same expertise as if you live in San Francisco or Boston or New York City. And so how did we do that? We did that mostly through expert medical opinions. We then launched navigation because we realized we were discovering too much too late. So we would change diagnosis 10% of the time, change treatment plans 60% of the time with these expert medical opinions. And we said, we got to go upstream. We got to get people to high quality primary care and specialty care before the expert medical opinion changes the outcome for this patient. And then we realized we also have to be a part of the supply solution. So we were trying to help members make the best of the ecosystem that existed today, but there was not enough primary care, there was not enough behavioral health care to care for the people who needed it. So we acquired a company called Doctor on Demand. Doctor on Demand offered 24/7 access to urgent care, behavioral health, and primary care across all 50 states. They had really built out that technology and ability to do that. And so with that, we both could provide some of the care directly and provide wraparound services for folks to use their healthcare system that they had as part of their health plan or in their local community, in addition to this sort of extra supply. We also bought a company called Included Health. The whole company took that whole name, and Included provided concordant care for people of the LGBTQ+ community. So making sure that if you are from a marginalized community, you are getting the outcomes you deserve. We merged, we took the name Included Health, we brought all these products together in what we call all-included care. So really, you now come to us, whether it's about your mind, body, or wallet in healthcare. We started taking value-based payment against that product set earlier this year for the state of California and the people who work for the state of California. And we're continuing to grow and build out all of the things people need in their healthcare. So what is the problem that we solve for our clients who are mostly self-insured employers or the purchasers of healthcare? This is not surprising to you. From the person perspective, this morning we talked a lot about all the problems in healthcare from the healthcare system's perspective. If you are a person, you don't understand your benefits. You don't understand what a high-quality doctor is. Most people don't trust your health plan. A lot of people don't even trust their doctors anymore, unfortunately. That was not true 20 years ago. 1 in 5 Americans does not have a primary care doctor. And you are paying more for healthcare out of your own pocket. You probably are all experiencing this in your day-to-day. And if you're a purchaser of healthcare, right, healthcare is like the #2 cost for most companies in America after the thing that they do. So if you're a retailer, your #1 cost is your supplies. You know, you're buying things. Your supply chain might be a threat right now. Your #2 cost? Healthcare for all those people who work for you. So you've got to manage those costs. And those same people whose healthcare you are paying so much money for, they're not showing up to work because they're not being productive, because their healthcare is not actually the experience it should be. They spend a lot of time on the phone with insurance companies and with doctors' offices. They're not as productive as they could be because they are also lost in this thing we call the healthcare system. So that's the problem that we face, and our solution is integration. So we're the phone number on the back of your insurance card. I talked about the sort of primary care doctors and behavioral health doctors we have. We do expert medical opinion. We help you with your pharmacy bills. We still do our expert medical opinions. So if you have a rare diagnosis or if somebody recommends surgery, we'll help you get that second opinion to make sure it's the right thing. And we've grown from a team perspective. So I have a lovely about 1,500 clinicians who work for me. They take care of people day in and day out. And we have a network of specialists that we use as well. And then this is who buys us. So you might be like, how do we get paid? So mostly it's large self-insured employers, as you can tell. They use us for their employees and their families. And then we also sell to some health plans, mostly on the virtual care side, so as a supplement to their network. And we are technology and humans. So when I first came to Included, it was okay, gosh, technology has to actually make healthcare better for people. There's a lot of technology in the world of EMRs coming to I was not a technologist either. I just want to make populations healthier and make it cost less money for America. That's like my goal in life. I was not a technology person, but technology should be helping us do this. And I didn't feel that way, even though I was in the wonderful place of UCSF, that it was actually doing that. So going to a company that is actually trying to use technology to make healthcare better for people was sort of the integration. So that's what we do.
The doctors, can I see a doctor in person in the company, or it's all virtual?
It's all virtual for now. We will refer you to an in-person doctor who we will promise you is high quality and matched to your needs.
And the doctors who work for you just work for you, or is it one of their gigs and they can do other things?
We have a mix. So about 80% of our clinicians are full-time employees with us. And especially during surge seasons like cold and flu, which we'll approach, many of those are independent contractors. So they will work for other companies as well. And on the behavioral health side, many behavioral health folks still want to keep up a private practice. So we'll allow them to sort of both keep their private practice up and work for us.
And why would someone work for you as opposed to as part of a medical group, working for themselves, working for a health system?
Yeah, there was a couple of people who mentioned burnout earlier today, I think. I don't know. So it's fascinating to me. So for every job I open, I get over 200 applicants within a day.
Like for a primary care doc?
Yep.
It's not, those aren't bots, those are like humans?
Those are real humans applying for jobs. And on the leadership side, I was just talking to Sachin, I just hired someone from the Brigham actually, like as our head of psychiatry. People do not feel alignment to the mission or the places they work anymore in healthcare. They want to go to a place that is mission aligned, actually cares about you, you can be engaged, you can actually be part of the solution, not part of the sort of problem, for lack of a better word. And so I think that's what we are seeing from a sort of why people want to come work for us. And then there's like some real perks. You can work from home. You can live remotely and serve anywhere in the country. So I do think we get some of the benefits of the flexibility of the work that we provide.
And your work, do you cover all of the specialties? You said you do the second opinions, but if I'm seeing you for primary care and then I need to see a cardiologist, what happens?
We'll use our provider match algorithm to refer you to the highest quality, best match cardiologist in your network for you.
But then the ones that use for second opinion, same idea. They don't work for you. They have some contractual arrangement to do a second opinion.
Exactly. So we have arrangements with 40 of the best health systems across the country, and then we have a lot of individual arrangements for the expert medical opinions.
And you said it's sort of a technology first company. Like, how are you using technology in ways that you think are interesting?
Well, if I think back to 2018 when I joined, we had the provider match. So it's basically, so when you are looking for a cardiologist, so what used to happen, if my friends or family needed a cardiologist, they would text me, be like, Amy, I need a cardiologist. Who should I see in San Francisco? They would even ask me about Ohio. They'd be like, okay, I'm in Ohio. You, Amy, tell me which cardiologist I should see. Like, I would know. That is like not a scalable solution. What we did is we built out using what was then called machine learning, now people might call it AI, actually taking all of the claims data across the entire country, so we had 95% of NPIs covered, and actually said, who are high quality doctors? Let us predict who will be the highest quality doctor, and then we'll match that to the patient. So if you also have my claims data, you will know what are the things that are most important for me when I am looking for a doctor. And then those two things produce a match, and we will stack rank that and use all of the same things that like a Netflix uses or a Amazon uses to know my preferences and rank them in the order, so I can just go 1, 2, 3 and pick the doctor I want to go see.
And do you have any financial risk or arrangement with that specialist once they are just going? So you have no incentive to send the person to a high quality but low cost, or how are you thinking about the integration of quality and costs as you make those decisions?
So the way we think about it is safety first, quality second, then it's efficacy, and then it's cost. And so those actually all go into the algorithm. So if there's two doctors that would be equally matched and one is more cost less than the other one, they will be ranked higher. But if the higher quality person is a higher quality person, they get ranked higher. One of the reasons employers like our neutrality is because we don't actually have provider contracts. So if you think of any health plan, they also have quality algorithms, right? So you can get your premium blue distinction as a doctor. But many a times those are negotiated things between a provider system and the health system. Like there's like 90% of doctors can become premium blue distinction. We have no actual contracts with the doctors, so it's truly objective in as much as the data can be objective.
Tell us about life in, as you said, you're not quite a startup anymore, but you are still a young, non-legacy company jumping into the healthcare system, seeing a bunch of niches that clearly are not served well by the existing healthcare system. And I think people sort of look in on startups and have different fantasies about how they work and how they pivot from one thing to another, or decide to buy a company or merge. Or so how do you think, how does that actually work? Like what would I not understand about how that works as a layperson?
Yeah, one, we're still human. We're still people working in healthcare. But I think the things that were the most surprising to me is, so one of our company values is actually we value change. I can't imagine a legacy healthcare company having that as one of their corporate values.
We have that, it just, they put the word no in right before it changed.
That sounds about right. But that is like the fundamental difference if I think of a legacy healthcare company and a place like Included, and there's many companies like us. We actually welcome the change. And our clinicians, when we hire them, they also have to welcome the change. We rolled out our AI scribe last year. We looked at all those companies. We decided they're all fine but commoditized, so we could just build our own. So we built our own. That was faster and cheaper. And then we had to adopt it. And the clinicians who didn't adopt, they kind of don't really fit into our culture. Mm-hmm. And so it becomes a sort of part of their performance. You've got to adopt this AI. This is part of what it means to work at a technology-first healthcare company. Our culture is one that no matter who you are, you're gonna change. And so that I think is probably the biggest difference. The other is pace. So when I was at UCSF, I think I was one of those people who moved faster than the rest of UCSF. And then I came to this company and I was like, oh, we all move fast. I think about, I joined in 2018, I launched my first product in 2019. We've launched like 4 products since there. We've done a merger, we've done an acquisition. We do something new every 6 months. Mm-hmm. And we grow constantly. So that is a little different.
Yeah, how does that work? I mean, there's always been the famous Silicon Valley mantra, move fast and break things. And then there's the usual response, well, we can't break things in healthcare, that's fine for a restaurant app. So how do you balance the tension of moving fast and trying not to break things?
Good. So 2 things. One, we've always had we had a clinical co-founder. So I think that helps. So my boss, Owen Tripp, the CEO, and Rusty Hoffman founded the company. Rusty is an interventional radiologist at Stanford, and they founded the company together. So there's always been very strong leadership from the top. I'm the chief health officer. I sit on the executive team. I would say there are startups where there is no doctor in the executive team. That's a warning sign in my mind if you're a healthcare company. So that's sort of some basics. We've always had a quality and safety team. So we have this team called Clinical Excellence. They look at our quality, they look at our safety, and I would argue we are held to more scrutiny than a traditional healthcare system. Like, our calls get listened to by consultants and auditors. And
hired by who?
By the employers.
By the employers. Google will say, we're going to audit.
We're going to audit.
Yeah.
Yeah, we're going to make sure you're providing high quality care. We sign up for performance guarantees, so we get paid if we deliver quality care. We don't get paid as much if we don't deliver quality care.
Do people speak French?
We do. That would be an interesting one. No, we do use a translation service. But we can get picked out. It's the same idea of if there's one bad call, there's one bad call, and we get called out on it. So there is a lot of, these employers are paying us directly to do something. And so they're going to make sure that their money is getting well spent. Mm-hmm. So there's a lot of watching of what we're doing.
It sounds like you've done a lot of changing over, now it's like 7 years there, new programs, new companies. But are there examples of things that you decided not to do, that you're allowed to talk about, that you thought actually this is too risky or not quite the right direction?
We get ideas all the time from our clients of what we should do, and we say no a lot. And sometimes we make the right call, and sometimes we don't. One of the lessons that we've learned is you don't launch a product unless you have someone to buy it. Sort of probably makes sense, but sort of. really important. And so a lot of our ideas for our next product come from our clients. They will say, our members are really struggling with pharmacy. Can you help them navigate that space? They will say, our cancer patients are falling through the cracks. What can you build for cancer?
So what'd you build for cancer?
It's a good one, and it's one that we're gonna have to modify, so it's a good example. So for cancer, we built, really I would call it like almost enhanced care management. So at the time, the places where people really struggle is when they think they're about to have a diagnosis or they have a diagnosis and they don't have a care plan. So at that exact moment, getting them to a high quality oncologist quickly, giving them the behavioral health support and giving their family the behavioral health support they need in that moment. So if you think about it, making sure the teenager or the mom who just got diagnosed with breast cancer has somebody she can see to talk to about that, and we can sort of get that in right away. And then we'll help cancer. The biggest thing that has made these members happy is we help people with their bills. There was a...
Yeah, what's that mean, to help them with their bills?
Yeah, so there's a lot of misbilling in American healthcare. So you get a $1,000 bill and you don't know what to do with it. You don't know if it's accurate. You don't know if you're supposed to pay it. And so we have an entire team. They're called our claims advocacy team. All they do is advocate these things. I've used it myself. I just used it. I got like a random $3,000 bill from our pediatrician. It was a mess. But I just took a picture of it. I sent it through messaging to the team. And like, you know, they're like, okay, we'll get back to you. In a week, they're like, I was wrong. You only owe $100. You'll get the new bill in the mail. I was like, sweet. So like, these are the things people struggle with. And you just struggle with it more if you have a diagnosis of cancer because it's so extreme. But it's, people deal with the same things. It's mind, body, and wallet. That's like what you want to be taken care of. And
But it seems like, I guess, cancer, as I think of coordination, so much of it is sort of intra-system coordination, and you're not in the system that's delivering their cancer care. It's sort of between the oncologist and the rad-onc people and the this and the that. And are you? I don't see where the point of leverage would be for you to intervene in that.
yeah, so in cancer we are pivoting because it turns out like that's correct. But our clients were still struggling with it. So one, not everyone is getting their cancer care at a system. So if you think of America writ large, actually a lot of people's care is very fragmented. It's very different if you're coming to the UCSF Cancer Center and it's sort of all taken care of. If you don't have a cancer center where you live, you're getting a general oncologist who's telling you something, your primary care doctor is telling you something else, rad-onc is over there. It's not actually that coordinated, so we can help a lot of folks who are struggling in that space. And then a lot of it's just, like I'll use an example. There was a patient who walked out of her oncologist appointment and was like embarrassed to ask a bunch of questions she had. But she should have asked her oncologist, but most people are kind of scared of their oncologist. And so then she called us afterwards and like, now can you just re-explain all this stuff to me? And you know, how will this affect how I'm showing up to my kids' school and more? Like, it's stuff that people want to talk to their doctors about, but either can't because of time constraints or can't because they don't feel comfortable. They sort of need that wraparound service.
You talked about that you built an AI for scribing. What else are you, like, that struck me as an example of they need an explanation for X, Y, and Z, which the bots do pretty well. So how are you deciding what's an AI thing and what's a human thing?
Yeah, so we started mostly on the member services side. So if you think of like the stuff that is, to use yours, low risk, high feasibility. So it's stuff like, what's my deductible? How much do I owe on this? Is this provider in network? Is this provider out of network? So those all used to be answered by humans. So we moved a lot of that to our AI bot. Her name is Dot. So Dot answers a lot of those questions for most of our members today. But with a pretty high deflection, we're very comfortable going to a human if needed. We just started piloting some of the clinical stuff, obviously moving not practice of medicine, but the stuff before it. So educate me about pneumonia. What do I need to worry about if I've got cellulitis? Like, sort of the basic informational stuff that people would also ask their doctors about, but now, you're not doing anything except education, so that can all sort of start to be handled by Dot as well. And then what we think of is we've got the brain. The brain uses Dot for the patient, and then it's Dash for the sort of care team side. So the member services team member or the clinician is seeing the same, it's all coming from the same root. So if you do talk to the doctor, sometimes doctors don't know what your deductible is. But we can actually tell the doctor that. So the doctor can chat, okay, so what is Amy's deductible right now? Like, can you tell me so that I can?
There's a doctor in you're one of your doctors.
Exactly, right.
Yeah.
So in our system, the doctors and the care team members can see the same information that the member can see because it's sort of built in the brain. And it's serving two fronts, the member or the clinician. There's really just one picture.
What's the electronic health record environment that you work with?
We just switched. We had a homegrown EHR until a year ago, and then we switched to Athena.
Why?
Turns out using a lot of engineers and product folks to make and maintain what's basically a commodity item is not a great investment thesis. So it was just easier to buy something off the shelf than to continue to invest in building it on our own.
And then as you do AI stuff, is it you develop all that yourself or you're out in the market looking for good stuff?
We both. We never want to build something that's cheaper to buy. But we do build a lot of it ourselves. So far, we found ourselves to be faster than most things we can see on the market. We use all of we use OpenAI, we use Google's model, we use all the LLM models, but can build off of them ourselves a little bit faster. I think that will change. It's just like the EHR thing. Like early days, we had to build it on our own because there wasn't an EHR that could support a national practice that needs to think about just cross-state licensing. And so we had to build it on our own. Over time, somebody could do it, we could switch. I think that'll probably happen in different features of AI as well.
It strikes me that you have relationships with your patients, with your clinicians, but also with all these companies. And all these companies, I assume, look at healthcare and just can't believe how screwed up it is. Do you get those conversations, and how do you answer that?
Yeah, this was one of the reasons of the many companies somebody can go to from the traditional healthcare system when you're looking to leave. It was the fact that we sold to employers that was one of the most attractive to me, because the incentives are like very aligned with the person. An employer wants their employees to show up to work, to be healthy, and be productive. And they don't want to spend a lot of money on all that. The member kind of wants the same thing. You want to be able to live your life, not be distracted by the headache that is healthcare, and not spend a lot of money. Kind of same, so that is one of the things I appreciate about our clients, that they are very aligned. And yeah, they don't get it, and they are frustrated by it. McKinsey just came out with an article, or a report last week. 165 million Americans get their insurance through their employer. It is still the number one way most people get their health care. The government would be the second, Medicare and Medicaid, which you guys talked a little bit about earlier today. It's $800 billion that employers are spending on healthcare. They are going to become the activists. So as we think about what might change this whole thing, they are frustrated. And they're willing to try new things. They're willing to be like, okay, Included Health, we're going to bet on you. Go help us make this better. Or, okay, Centers of Excellence company, we will only send patients to these 10 places that do cell and gene therapy, or these 15 places for knees and hips. Many of them are launching very narrow network products right now to manage the total cost of care. They're willing to move in the world of AI. So we have a big client who's been pushing, two clients who have really pushed us on the DOT thing. So again, to the point, we don't do things really unless our clients are asking for it. They're like, you have to bring AI to member services because it is crazy how much we spend for these things. And we're like, okay, let's do it.
Because it's the cost, or it's that we've done that in our company and it's working really well, and I can't believe that you're not doing it?
Both. So we have like the Googles of the world. We obviously support some of the top technology companies across the country. And that is what, from top down, the benefits team is hearing. Everything about this company is transforming healthcare. The way our team members experience healthcare better transform too. But also, from other clients who are not those companies, they just want it to be cheaper and better. They just see AI as the tool to get there, but that's the push from them. So but I do think that employer activism is coming and might be one of the big reasons healthcare might actually change.
Why do you think it's coming now and not 5? I'm just always struck by this, like, we're hitting a moment now, but like, really? We had a moment 5 years ago, 10 years ago, and 20 years ago. Like, what do you think it is about now?
I think there's this moment right now. So they are seeing the trends go up. So on average, I think it's 8% increases across the country this year. 10 to 12% in some states is what many employers are looking at as they look to their premiums. And then you're stuck with the, what do I do about this? There's a couple things. You reduce the salaries of the people who work for you.
Then they go on strike.
They go on strike.
Yeah.
I mean, it's starting to get truly unsustainable. It used to be an employer was comfortable letting this be the job of HR. Now the CFO's in there being like, okay, we really can't have this keep happening. And I do think their members are also mad. I mean, one of the things that's been, so with the state of California launch, in the state of California, it's a budget problem. So for those of you who live here, you want the state of California to figure out how to make healthcare cheaper because there's only so much budget. It's firemen and fire people or it's healthcare. And so they are at that point. But the members are also complaining all the time. They're like, we're spending all this money and the amount of noise these benefits folks are getting from their membership is complaint. I can't get in to see a doctor. I can't survive. So they're just stuck in this bad experience, too much money.
Got it. And those two don't cancel each other out.
Unfortunately, I wish they did, but they don't. They don't.
How are you at scale? You said we send patients to the best doctor or the highest quality doctor. We have our network of doctors who work for us. How are you monitoring them in real time, and how much emphasis are you placing on standardization and that they are all doing the same thing the same way, and how much pushback do you get on cookbook medicine if you do that?
So for the folks who work for us, we have a lot of guidelines they're supposed to follow. We're obviously using AI Scribe. We use a lot of templates. So there is standardization. There's also the humanity of medicine. And it is like you are, at the end of the day, you're an individual doctor with an individual patient doing what's right for them. So that balance, I think, is true for us. It's true everywhere. But you're measured on your outcomes. And so our outcomes at the highest level, like the thing our client told us to, are we delivering more healthy days for the member? So that's a CDC measure. You ask the patient in the last 30 days, how many of them were you healthy? Did you feel healthy physically and mentally? You subtract it by 30, you get a number. It's a very top level metric of how's your population doing and its cost. But then you go down. So for primary care, we're used a lot of traditional metrics, the HEDIS metrics. It's not that surprising. For behavioral health, it's things like PHQ-9, it's GAD-7, it's all standard metrics. We also measure member satisfaction at the physician level. We also measure NPS at the physician level. So we also are measuring experience in addition to those basic quality and safety measures.
Part of the challenge in the insurance plan business is the time horizon. And if you only have someone for a year, you might have, so I'm wondering, is the companies have some of that time horizon incentive? You could see, all right, we want you to fix their knee pain because they're out of work, but fixing their hypertension or their diabetes may not relate to something that is they're in or out of work in the next year. It might be a 5-year, 10-year time horizon, and just how people churn out of insurance companies, they may churn out of businesses too. So how do you think about that time horizon issue?
Yeah, I'm very much aligned that I wish I could provide insurance for people for their whole lifetime. But we will never enter that phase in America, I don't think. We're going to have this weird system where you change your employer, you change your health plan, and different people are holding risk for you at different times. A couple of things that we've noticed. We do have clients where the average tenure of an employee is like 1.7 years. That's super tough, right? Because you really only can get so many savings. There are still savings to be had. And there's still outcomes to be improved. But there was a time where we had we had all the top retailers in America as our clients, and really the same people go to these places. So they're all sharing their employees, right? You work at Walmart, then you go to Home Depot, then you go to Target, same people, they just are going in. So there was, I think Owen and I had this hope that maybe they would all come together and just be like, we're all going to get the bill at some point. It's just who's left holding that bag at year 20. I'm not totally convinced them of this yet, but maybe I can still dream. But some of our clients, people do work there for over 20 years. So if you think of states, if you think of a lot of the companies we have, the average tenure is more on the 7 to 9 to 10-year range, up to 15 to 20. And those companies are much more incentivized to sort of invest in primary care, invest in the preventive stuff. But you're right, there is this inherent
They're incentivized,
tension.
and do you feel there are differences in what they do? They do more of it?
We only sell a certain type of package, so they end up having to buy the same thing from us.
They can't pick and choose sort of various levels of it?
They can. You can buy only expert medical opinions. You can buy only the virtual care. And so are the clients who are buying the whole integrated package mostly, actually it's not true. Some of the short tenured folks do too. But what we try to bring is, this is the best standard. This is what you should sort of get.
Is there a prior auth issue in your business? Like, do I get a prior auth from Google to get an MRI scan, or that goes away when the employer is providing the coverage directly?
They still use their health plans for so if you're a Google employee or anything, you still have the health plan who does all of the prior auth stuff and does your utilization management. For some of our clients, we've taken over the utilization management function, but that does still exist.
So your docs may need to get a prior auth to get a test or a treatment.
Yeah. A lot of them are starting to, as we think about alternative plan design of the future, this is a place where we're getting a lot of questions of how can we get rid of prior auth. So if they were to
You get questions about just how can we get rid of the health plans?
Yep. We get all of these questions.
Right.
Yes.
So, and why can't they?
Right now, if I think about it, there's certain things we really do need health plans to do. We need them to pay claims. Like you need the TPA function versus the health plan function. You need them to own the network. So you do need somebody to own the relationships with all of the provider groups. That's really what I think we need a health plan to do. Now, health plans obviously do a lot more than that, and they sell a lot more than that. But if they could do those things remarkably well, I think you could have companies like ours do the rest of it. Do the interactions with the members, do the actual interactions with the network to make sure that patients are getting what they need.
What does the success, and I assume your company's being successful, of your company say about the state of primary care and the future of primary care in the US?
It's not a great moment right now. And I think in this room, everyone probably knows what primary care means because we're at a healthcare conference. I bet you, though, if you walk down a street in a random street in America and you said, what is primary care to people of all different ages, races, demographics, I think a lot of people would say very different things. Some people don't actually know what a primary care doctor is. Their primary care doctor is the urgent care that's open on the corner that they walk into when they need something. Their primary care doctor might be their best friend. You know, like people don't actually know what that means. And I don't think it's like the best product with the worst marketing strategy. I also don't think people know why they should see a primary care doctor.
Right.
Because they're never available. We need to really fundamentally rethink what people want, and maybe we shouldn't label it primary care. I think what people want is they want somebody or a brand or an entity that they actually trust, who knows them deeply, who can make recommendations that are applicable to them quickly. And the reason, it might be a person, it might be not a person, but that's what people want, and they want it in their pocket. They want it available every day. They do, I think, they will need somebody who can both touch them physically when that's necessary and fix things, as well as be available by phone, by text, by chat, all of the ways we communicate in all of our lives. That's what people want. Now, if we want to call that primary care, that's great. But it is really like the best product with great outcomes, and somehow the marketing fell apart.
If I'm seeing you for primary care, am I seeing the same person every time?
Yeah, we have a lot of belief in that continuity of relationship. We always give you the choice. Do you want to wait a week to see Amy again, or would you rather see Bob in 20 minutes? So it'll be up to you, because you might actually not want, if it's urgent, you might not want to wait for me. And our
usually
urgent
Bob
care,
in 6 months is the issue.
That's the problem, right? Yeah. So our average wait time for primary care is, I think it's like 4 days right now. We promise in a week. And our wait time for urgent care is 10 minutes. So those are your choices: primary care in a week or urgent
And your
care in 10
primary
minutes.
care visits, are they 15-minute fire drill, or how do you deal with the timing?
So they're 30 to 45 minutes. It's all virtual. There are things that you do to make a virtual appointment more effective, right? Like one of the early innovations was, don't have the screen over here, so the doctor's like looking like this. Put the screen in the middle and the charting under it. So you're looking eye to eye, even if you're through a virtual screen. So, but no, these are long visits. We're not trying to rush you. in primary care. Urgent care is much faster because it's usually in and out. Like it's COVID, flu, it's a rash.
And there have been a lot of regulatory and payment changes around virtual visits that have, 1 week it's sort of in and the next week it's out and the next week you need a license in a different state because you're in a different state. How have all of that affected your ability to do your business?
So there was one silver lining in the, I won't call it what it's called, the BBB, for companies like ours, which is the safe harbor got permanently extended. So historically, to your point, there was a lot of back and forth on will telehealth be covered if you're in a high deductible plan or before the sort of high deductible kicks in, and that all got extended permanently. So if a company wants to make telehealth $0 copay or lower copay, they can do it and not risk the tax status through the HSAs. And so that was a big benefit to our company. They also really did put in a lot of incentives for direct primary care. So companies like ours can sell in the sort of tax protected bracket from a ERISA perspective to employers, these direct primary care plans. So there was actually something very small, but that was positive.
You think those things were beautiful?
I do think those things were beautiful. So it's a small, beautiful bill.
Small, beautiful bill. Did they do anything about the whole, do your people need state licenses at every state?
No, that's going to be a state thing. I don't think that's ever going away.
So
I mean, I wish. Actually, they did.
You hire a new doc and they need to get a license?
Yeah, they did do one thing. They did put in incentives to have more states join compacts. So physician licensing is the most complex. Every time we hire a doc, we have to get them licensed up. Nursing compacts are pretty good. Like they cover like 30 states, and NP compacts are pretty good too. But so there are actually incentives in the BBB to try to incentivize more compact approaches to state licensing. But yeah, we license a lot of people up.
You do. What have you learned about the training of doctors from your experience now hiring and employing a ton of them and in a different and maybe more nimble and ever-changing practice environment? What are we getting right and what are we getting wrong in training?
I've been thinking a lot about this just with the role of AI. I mean, I think we talked about this earlier. All of our clinicians obviously have up to date. They have open evidence, all tools that they can use at their disposal to take care of patients. I think that makes care better. We use AI to actually quality monitor all of them. So we've launched like sentiment analysis and QI. That's how we do, quality at scale across our clinicians now.
Sentiment analysis of the patients, how they felt. Is that from looking at their face or from what they tell you?
Sound.
The sound of their voice.
Yeah.
From the sound of their voice, you're going to judge whether the person liked it.
Yeah, so if I wanted to review a call of one of my clinicians, you can obviously see the whole transcript, but we'll have it's like goes from green to yellow to red, back to green. Like you can see the patient's mood during the call. It's fascinating. And then you go listen at that one point.
When the patient says, you're not listening to a word I say, but does it in a nice, happy voice? Does that come through?
No, that's when you have to go to the transcript. But you can start to hear, or if they're pausing a lot, they're not answering. And we do this on member services calls too, because again, whether it's clinical or non-clinical. But I think as technology, as we as clinicians need less and less to keep a lot of information in our brains, which, if I think about how I got to med school, how I got to residency, a lot of it was like, how much information can you keep in your brain, Amy, and then regurgitate later, right? That is not at all what it takes to be a doctor anymore. What takes to be a doctor, I think, is what you talked about in your last paragraph. It takes actually listening, not interrupting, caring, handling complexity and ambiguity with ease, being cool when your patient shows up and tells you exactly what order to test because they already asked ChatGPT before they showed up, and not being like, oh, why are you doing that? Instead of being like, I'm so glad you did that. Let's talk about it. Those are the skills that will keep us in business. Doesn't matter how much information you can keep in your head anymore.
Yep.
In my opinion.
I'm with you. Thank you. That was great. Appreciate it.